Good evening, tēnā koutou. My name's Lucinda Thatcher and I'm the coordinator of the Rural CME program through the University of Otago section of Rural Health. Welcome to this, our first webinar of 2022. Isn't it amazing that we're already a quarter gone? It's quite exciting sitting here and having a look at everyone's names as they pop up onto the screen, and there's more and more that I recognise. There's still a few names that I don't recognise, but hopefully through the year I'll get to meet some more of you. It is with great pleasure I welcome and thank David Young, who has just told me, even though this is our first webinar, that this may be his last. So we feel very, very honoured to have that privileged position. And David is a dermatology specialist based in the Southern DHB. And this evening, we're going to cover a number of skin-related presentations, particularly that we think will be relevant in acute dermatology in rural practice. And we're going to take advantage of David's experience working with our rural colleagues down south. And so he certainly has a grasp of our rural context. This evening is run by the University of Otago section of Rural Health in conjunction with the Division of Rural Hospital Medicine. It is endorsed for 1 hour of CME by the Rural New Zealand College of General Practitioners. I can lodge the CME points for you if at the end of our session you complete the feedback poll and insert your medical council number within the space provided. David, I will now hand over to you to start, and we will pause when questions come through. So anyone, if you have any questions at any point, please put them into the chat, and I will ask Gary to ask them as the time goes on and and we find points of pauses. So I'll hand over to you now, David. Thank you very much.
Thank you very much for the invitation, and I'm glad to be here. Yes, although I spent most of my practice life based in Dunedin, I did clinics in Timaru for 19 years and Queenstown for 20 years and Alexandra for over 25 years. And I currently do clinics in Southern Hospital. So I've been probably one of the more rural dermatologists, and mind you, people in Auckland think Dunedin's rural anyway. So during my career. So now we're all specialists here, but not quite as flash as Dr. Smith, the podiatrist, who's a specialist, but left foot only. So we're not going to be quite that narrow in our look tonight. What I want to cover, what I've planned to cover, is presentations that, especially for the rural hospitals, etc., that you may end up with. And I want to talk about erythroderma. I'll talk about the more serious drug reactions, and because it's a bit of a minefield, and to give you some sort of plan to sort them out. A little bit about atopic dermatitis. As Lucinda knows, I'd rather spend the whole thing talking on atopic dermatitis, but a little bit about that. A bit about bullous disorders, and then if we've got time, some of the cutaneous manifestations of COVID. So no doubt you've all heard of exfoliative dermatitis, which is the old name, but now we tend to use the term erythroderma. And this is where people present with red skin involving most of their body. It may just be red and fiery, it may be oozing, it may be scaly, and there are a number of pictures of various origins of erythroderma here. So it's a very uncomfortable, often acute, but not always, presentation. It may have been coming on for some time. There may be total skin involvement, fiery red. There may be scaling, bit of oozing that's crusted. There may be islands of sparing in some conditions. And usually the palms and soles are involved, and if it's chronic, it may produce some pigmentation as well as the underlying inflammation and scaling. So when you're presented with this, can be any one of a number of causes, can affect any age, all races, more common in males. Most have a pre-existing skin condition, which makes it a little easier to sorted out, or a systemic condition known to be associated with erythroderma. But 30% of people are idiopathic. And as I say to my patients, that if they ask what idiopathic means, it's where it is and don't really know what's causing it. So the most common skin conditions, dermatitis, especially atopic dermatitis, I would certainly see on average, 1 every week or 10 days, a patient with atopic dermatitis that's gone like this. Psoriasis is the other major common cause, especially if they've been treated with systemic steroids. We don't use that for psoriasis because if you withdraw them, this is what's happened. And if they've thrashed dermal or another potent steroid for years and then suddenly stop, this happens. And it can happen in atopic dermatitis as well, but although it can just present on its own. And it can be part of a drug reaction. And I'll talk about that a bit more when we talk about drug reactions. Other forms of dermatitis can produce it, prodromal pemphigoid. There's a condition dermatologists get very excited about called PRP that can do it. Sézary syndrome, which is the erythrodermic form of cutaneous T-cell lymphoma. And then there are a number of very small print congenital ichthyoses that can do this. So what systemic disorders are associated with it? Well, hematological malignancies are probably top of the list. Internal malignancies, occasionally. It's not something that you pursue in great detail other than a detailed history and examination. It's not like, for example, if someone presents with acquired acanthosis nigricans and you're wondering about stomach cancer, etc. It's not that common with internal malignancies. Graft versus host disease and HIV infection are other systemic disorders.
Can I just ask you, David, in terms of the association with atopic dermatitis, what tends to lead to erythroderma? You mentioned that link with psoriasis and withdrawal of systemic or potent steroids. Is there some other connection between atopic dermatitis and erythroderma?
Yeah, some people with very unstable disease will just present. They'll go from relatively localized disease to severe disease, and they will do this recurrently. And if you talk to them, it happens over a matter of a couple of days or so. Sometimes down this end of the country, people think it rains all the time, but as Gary will tell you, we're warm at the moment, but generally it's a cool, dry climate in the lower South Island, which is one of the worst climates for atopic dermatitis. So over winter, that will do it. Again, withdrawal of steroid or either topical or oral. If they get some secondary infection, it can just occur a bit spontaneously in a lot of them if they're going through that very unstable phase.
Right, thank you.
But they're itchy, most of them. They get eyelid swelling. The scaling, which is where the exfoliative dermatitis comes in, begins about 2 to 6 days after the onset. And later on, they may get hair loss and keratoderma, which is that thickened palm soles. The nails may be affected. And generally, they have what's called a dermatopathic lymphadenopathy. Because their whole skin's involved, all the lymph nodes seem to become much more prominent. So what clues? I mean, obviously, if they've got a history of atopic dermatitis and the serous ooze, that's helpful. Persistent scaly plaques and psoriasis, and then some of the rarer things like islands of sparing, like in that picture I showed originally, that can be with PRP. And if they've got other systemic features, then some of the drug reactions like DRESS, which I'll talk about a bit more detail in a moment or two. It's more than just the skin thing, though. These people with this fiery skin can't control their body temperature. They lose heat, they can't conserve heat if it's cold, they get fluid loss, their skin barrier is shot. People, especially people with previous cardiac problems, can get high output heart failure. They're prone to secondary skin infection. They're also prone to pneumonia. They're shedding tons of first-class protein, and they may get pigmentary changes. So what do we do? Generally discontinue unnecessary medications, the typical monitoring fluid electrolyte balance, protein intake, lots of moisturizers. This is before you've got a diagnosis, mild, moderate topical corticosteroids, and treat any infection. With specific conditions, and the two main ones are atopic dermatitis and psoriasis, you may use short-term oral corticosteroids to get under control, but only while other treatments are having an effect. And so topical corticosteroids and other treatments may be required, and I'll expand on those again later. In psoriasis, topical treatment really isn't going to do much other than provide some mild relief. So they generally need acid retin or cyclosporin, both of which are on the general prescription list, or methotrexate, but methotrexate, as you well know, can take a couple of months to kick in. So acid retin or cyclosporin are usually the treatments of choice for severe psoriatic erythroderma. So that's that section. Just very briefly, if you're presented with the red man or the red woman or the red child, the sort of things you should run through. If there's...
Thank you. Gary, any questions? I don't think there is. There is there.
Yeah, no, not there at the moment, Lucinda.
Right.
Okay. I always love this cartoon, in case you can't read it. Something's not, two cavemen sitting in a cave. Something's just not right. Our air is clean, our water is pure, we get plenty of exercise, everything we eat is organic and free range, and yet nobody lives past 30. Oh, I've put a case in here. This is we'll perhaps talk about this later on at the end, because I've got 2 or 3 cases. 4-year-old child, recent febrile illness, thought probably viral, took a while to settle, had antibiotics, and got this coalescing papular eruption on elbows, knees, face, and a few elsewhere on the limbs. It's a bit itchy, but not drastically so, and the child's not desperately unwell. And the question you're faced with is this a drug eruption? Have a think about that, and we'll talk about it later. So what I want to talk is about 3 or 4 main drug eruptions and trying to make sense of the serious ones. We're all familiar with the amoxicillin rash and a bit of urticaria after penicillin and things like that, but how to make sense of the serious ones. And one of the doyens of drug reactions is Neil Shear, who's a professor of dermatology in Canada. I can't remember where, it may be Toronto. And he's written the book and the online database, but he has a very practical approach, and he uses Shear's diagnostic triangle, looking at the appearance of the rash, the systemic features, and histology. And the least important of these is histology. The clinical appearance is far more helpful. Histology may be helpful, but it's the least important of the 3. And he has a great way of giving you, are these serious reactions or not? And it's, Lucinda, the pictures are covering my right-hand side. They're not covering yours, are they?
No, it looks, yeah, looks good.
You've got the full screen, have you?
Yes.
Yeah.
Yes.
Right. So Simple, we all are familiar with the simple drug rash with urticaria, perhaps acneiform eruptions, and blistering disorders like fixed drug eruption or any form of blister. But what we're talking about tonight are the complex reactions that you need to be a bit concerned about. And distinguishing this from this, the major symptom is fever. That's what's covered on my screen, but you can see fever there, can you? Yep.
Yes.
So that's what he uses to distinguish, give you the alert that this is something that you need to take a bit more seriously rather than just giving them a couple of antihistamines and a bit of 1% hydrocortisone. Right. Now, as I said to Lucinda the other night, everyone's got to have one of these slides, and I won't dwell too much on it, but there used to be type 1, 2, 3, and 4 allergic reactions. Type 1, you're aware of anaphylaxis, allergic rhinitis. Type 2, like hemolytic anemia. Type 3, serum sickness, immune complex disease. But type 4 is now divided into 4 itself. The first one is relevant to us, contact dermatitis. Then there's the eosinophil mediated one called drug reaction with eosinophilia and systemic symptoms, and that's DRESS. Then there's Stevens-Johnson, which is a confusing field in itself, which I hope to give you some idea about tonight, and TEN, toxic epidermal necrolysis. And then the last one is AGEP, acute generalized exanthemus pustulosis, which, although it says it's only about 5 per million per year, I'm sure it's more common than that, except we don't see it until a bit later on. So we'll talk about these. So DRESS, you just get a typical morbilliform maculopapular eruption. Occasionally it may be a bit purpuric, but it may just be like any other drug rash. It's mainly adults. It's thought there's a genetic sensitivity, susceptibility, and this stress used to be called drug hypersensitivity syndrome. You remember we always used to be warned with phenytoin and other drugs, allopurinol, that about 6 weeks down the track, patients could develop this. So the most common drugs are the anti-epilepsy ones. There's commonly cross reactions, allopurinol, sulfonamides, and a number of other drugs, but there's always the same old favorite group of the allopurinols, the sulfonamides, some of the penicillins, especially the beta-lactam ones, and the anti-epilepsy drugs. Usually it starts within 2 weeks of starting the drug, especially with the beta-lactam antibiotics. It can be delayed more than 2 weeks, so it may be 6 to 8 weeks with anticonvulsant drugs and allopurinol. And in some cases, if it takes 8 weeks to come on after the drug started, then they may have even in fact stopped the drug by then. And there's a genetic predisposition again, and it's thought that there may be some reactivation of human herpes virus 6 or EBV as part of it all. So these people present with that maculopapular eruption, but the difference is they've got a high fever. The morbilliform eruption, 10% may develop erythroderma, as I was referring to in the first section. They not typically, 20% of them get facial swelling, some mucosal involvement, and the rash may last weeks as opposed to the usual relatively brief 7 to 10 days maculopapular eruption. And the rash severity doesn't normally correlate with the severity of internal organ involvement, and that's the problem here. There's often multi-internal involvement, and the symptoms may continue to worsen after the drug's withdrawn. Significant mortality. The systemic disorders are acute liver failure, multi-organ failure, fulminant myocarditis, and hemophagocytosis. Treatment, drug withdrawal, obviously. Systemic steroids, and these people may need to stay on systemic steroids for months. And if you withdraw them too soon, they'll flare up and then be more difficult to control. Sometimes they may need immunosuppressive therapy, but usually systemic steroids and topical supportive therapy. And when they recover, they are at increased risk of other autoimmune disorders, apparently. Not that I've seen that. So DRESS stands for drug reaction with eosinophilia. They have a significant peripheral eosinophilia and systemic symptoms. So that's one.
Can I just ask you, David? So I just think in terms of the timeline with the drug exposure, and you may not actually be on the drug. So you could have stopped it, but still subsequently develop DRESS.
Yeah.
Yeah. Okay.
And so you need a history of drugs they've been on the last 2 months anyway.
Right.
Yeah. And hopefully, well, if they've got it, hopefully one of those old favourites will stand out as a likely cause. Yeah.
Thank you.
Now, there's a lot of confusion. This is on another one of the serious drug eruptions now. There's a lot of confusion about, we used to teach that it was a spectrum. You had erythema multiforme at one end, which we've all seen. It's the classic pattern recognition in dermatology. And then if you got a bit worse, it got turned into Stevens-Johnson. And then if you got worse again, it turned into that terrible toxic epidermal necrolysis. And so I'm hopefully either going to confuse you totally or make some sort of sense of this about the emerging classifications. So when we talk about TENS, we include now Stevens-Johnson syndrome and TEN, toxic epidermal necrolysis, TENS, or the TEN, toxic epidermal necrolysis spectrum. And I'm going to talk more about those. So this is Shear's classification with the complex, with the fever, and we're talking about toxic epidermal necrolysis spectrum. The simple bullous pemphigoid is usually not drug-induced, but it isn't being induced now by these new checkpoint inhibitors that many of your patients will be on. The important thing to remember is that erythema multiforme is not a mild form of Stevens-Johnson. Erythema multiforme is relatively common. Patients aren't particularly ill. They may be a bit uncomfortable, certainly frightened by the appearance. Most cases are secondary to herpes simplex, occasionally drugs, post-infection. And in fact, my colleagues in the States now say that anyone who presents with erythema multiforme has got COVID until proved otherwise. And
would they typically, David, would they typically not have a fever too, erythema multiforme?
Yeah, most don't, no. And their peripheral blood is usually pretty normal, and they're not systemically unwell. You know, they don't have painful skin. They don't have, they're not sort of tearing themselves to bits or complaining of pain and that sort of thing. And it's self-limiting over about 10 to 20 days, bit of supportive treatment, bit of topical steroid, and it will get better. Just as an aside, if any of your patients have recurrent erythema multiforme, it's virtually always due to herpes simplex. And if you can suppress the herpes simplex, you can stop them getting erythema multiforme.
David, when you say the term supportive therapy, which is you've said before, can you just clarify exactly what you mean by supportive therapy and see if it's the same as what I mean?
Explaining what's going on, the time course, because, you know, people say, well, I stopped the drug, it's still there the next day. They may get some relief from potent topical steroids short term. And if you want to, you can use an antihistamine. I'm not sure how much benefit it is, but those sorts of things really, because they're going to get better whatever you do.
And what's your definition of short-term topical steroids?
Well, it differs from the condition, but I mean, you're never going to do any harm giving someone a potent topical steroid for, you know, 10, 20 days, really. Well, certainly not. You wouldn't probably carry it on 20 days in this situation, but for 10 days. But most, or if you're using them, they'll probably start seeing some improvement in a week or so. Yeah.
Great. Thank you.
So this is getting on to the others. So erythema multiforme will section off. It's not part of this 10 spectrum. It consists of Stevens-Johnson syndrome and TN, and we'll just talk a wee bit more about those. Now, to confuse you again, there's two types of Stevens-Johnson thought to be. Essentially, it's all the same condition, but there used to be a condition called erythema multiforme major, where people got severe mucosal involvement, but they were febrile and obviously unwell, and had almost a sort of targetoid eruption. And these people are now called Stevens-Johnson type 1, and they're virtually always due to mycoplasma or possibly some other viral infections. And then we've got true Stevens-Johnson syndrome, where people are very unwell, febrile, severe mucosal involvement, and virtually all of them are drug-induced. So erythema multiforme is out of the picture. There's Stevens-Johnson type 1, this mucositis, classic, may have the classic targets, and it's now called SJS type 1, but was called erythema multiforme major. And these people get better with appropriate treatment, treating the mycoplasma and supportive treatment again. What you're worried about are the type 2 Stevens-Johnson syndrome, who get atypical target lesions, pain and blistering. These people are severely unwell and have mucositis and hemorrhagic lesions. We've all seen this condition, I'm sure, and they have bully on their skin, and they can stay at that stage, or they can go on to develop TEN, which is a horrible, horrible condition. So if you're thinking of Stevens-Johnson drug-induced, the treatment of choice these days is cyclosporin, 5, sometimes even higher milligram per kilogram. And most of these people will start improving in a day or so. It's T-cell mediated. Cyclosporin is the treatment of choice. They do need particularly good supportive care, oral mucosa, ocular mucosa involving the ophthalmologist, and genital mucosa, men and women. That can be critical to prevent fibrous fusion of the conjunctivae and all those sorts of changes. So it's typically a nasty condition, but cyclosporin has changed the SJS part of the spectrum a lot. What you don't want to see is them progressing to this. Toxic epidermal necrolysis can just occur out of the blue. It's virtually always drug-induced, or it can rapidly progress from Stevens-Johnson syndrome. And these people get full thickness skin loss. The mortality is very high. They just shear off their skin. And the treatment is you whip them off to an experienced burn centre as quickly as possible, preferably with who liaise with a dermatologist, and that certainly happens at Middlemore, which is, I think, where most of these people end up. It's certainly a very harrowing experience when you see someone sloughing off all their skin when they've only taken a couple of Augmentin or a couple of cotrimoxazole tablets. But fortunately, it's rare, but Stevens-Johnson's not all that rare.
Good to know. Thank you. I must admit I'm a wee bit, I haven't seen any of these, David, so it's all, you know, hopefully I won't. Should we finish? Gary, do you want to ask a couple of questions before we move on to this?
Yeah, thanks, Lucinda. David, one of the things that's always on our mind a lot is what's the appropriate point at which to ask for help and refer. And you've done a very good job in emphasising the importance of systemic symptoms, fever and abnormal blood tests and things like that. Would it be fair to say that as soon as we have evidence of more systemic involvement, such as a fever, then that's the time we should be referring?
Certainly seeking advice anyway, you know, I mean, because the problem is, as Lucinda mentioned, although I'm a dermatologist and see some of these, they're not all that common to the individual practitioner. So I guess if you're seeking advice would be the first thing as to whether you do need to transfer or not.
We're going to obviously be pretty reluctant to do things like start methotrexate and cyclosporin ourselves without first getting advice. What about those situations, which unfortunately is not uncommon around New Zealand, where it's quite difficult to get acute dermatologist input into these patients when they're admitted? Is the right thing for us then to consult the general medics at the base hospital? Or?
Well, you usually give me a yell and I duck over, Gary.
Yeah, but we're really, really privileged that way.
We're not all that lucky, David.
I'm acutely aware that that's not the norm around the country. I think we probably have the best service in all of New Zealand, in all honesty.
Yeah, some DHBs, and the Southern DHB is a prime example, don't get me started, have absolutely pathetic dermatology services. If you can get hold of a dermatologist, I'd speak to them. Certainly in some of the bigger centres like Hamilton and Auckland, at Auckland, South Auckland, Hamilton, it's far easier. But certainly speak to the general medical people as well, yeah. Because no dermatologist is probably going to manage these on their own anyway. They're going to involve in medicine as well when they're really unwell.
Okay, thanks for that, David. As you're going through the next series of conditions as well, then feel free to indicate to us the point at which you think that those conditions should be referred or consulted on as well.
Yeah, well, those are the main ones about what I'm speaking tonight, and I'm going to talk about a couple of conditions that are often referred, but don't essentially need to be if you're, well, I was going to say comfortable, that's the wrong term, but if you're prepared to manage them with advice. Like there's no dermatologist, Dunedin Hospital doesn't employ a dermatologist anymore. They contract an Auckland dermatologist to do clinics a couple of days a month. Southland Hospital contract me to do clinics a couple of days a month. So I frequently get calls from the Southland Hospital with email, pictures, etc. And I think that works quite well to a point. Although the hospital board doesn't believe it, but teledermatology has its limitations. As you know, sometimes you've actually got to touch patients and poke and prod them and things like that. So this is just the last drug eruption I was going to talk about. It's far more common than this, and I'll show you pictures in a moment, and I'm sure you've seen people like this in the recovery phase, and it's called acute generalized exanthemus pustulosis, or AGEP. Drug-induced again, the old favourites, beta-lactam antibiotics count for more than 90% of them. Others include, there's probably not a drug that hasn't been associated with it, but these are the common ones. Very rarely post-viral spider bite herbal preparations. And I won't spend a lot of time on the detail here, but it usually occurs within 2 days of exposure, so quite early on. Starts in the face, axilla or groin, becomes widespread, and the patients are literally studded with pinhead or 1 to 2 millimeter tiny sterile pustules all over. So it's something that should be easily recognized if you see it acutely, but I think a lot of us, myself included, don't see it till a few days later. There may be fever and the malaise, but they're not unwell, not like Stevens-Johnson or Dress, and multi-organ involvement is extremely uncommon. And it persists for 1 to 2 weeks and then peels off. So they present like this, all these tiny little pustules all over the skin. They may be a bit more prominent like this, but I'm sure you've all seen patients like this in the recovery phase with this sort of peeling skin. And you think, oh, it could have been a drug reaction to the augmentin I gave them last week. And I think we see this not uncommonly, but this is how it usually presents. They have neutrophilia, raised inflammatory markers. They may have these, although I haven't seen these abnormalities. And if you biopsy them, they have subcorneal pustules. They're often admitted, but they don't need to be if they're well in eating and drinking. They're usually not systemically unwell. Obviously, stop the drugs, moisturize, topical corticosteroids, systemic treatments really needed, and they desquamate off in about 10 days, and it doesn't recur unless you give them the drug again. So just be on the lookout for that. So this is a summary of Shear's classification. I mentioned EM, and also now Dress in the US and North America is presenting as a manifestation of COVID-2, so it can mimic a drug-induced systemic eruption. So, very briefly, I was going to talk about atopic dermatitis or atopic eczema. I use the words eczema and dermatitis to mean the same thing. And when people talk about holistic medicine, I think they often miss out the W. And it's a condition that's extremely common. 15 to 20% of the population have had it at some stage in their life, and generally poorly treated. A lot of these people will present acutely as erythroderma. They may not be true erythroderma. They'll present with an acute flare-up all over. And the days are long gone when you say to them, oh, yes, oh, yeah, you must be allergic to something. Take prednisone 40 milligram per day for 5 days, and then, we'll sort out after that. Well, they get a bit better, and then they get the most god-awful rebound flare-up when they come off the steroids. So the whole approach to atopic dermatitis has changed, and I'll talk briefly about that. So it's an incredibly polymorphic disease. All these people have got, from a young baby with acute weeping infected atopic dermatitis on the cheeks, typical hair, erythrodermic, head and neck, often in young adults. 80% of occupational dermatitis is atopic in origin. Erythrodermic, teens and adults often get eyelid involvement, typical flexural, typical patchy like this. It doesn't have a single cause. Monotherapy doesn't exist, and etiology and exacerbations are multifactorial, that terrible word. a lot of patients are convinced or have been convinced it's an allergy. And in my experience nowadays, many of them are relieved to be told it's not an allergy, although you have to reinforce that people with atopic dermatitis have an increased incidence of coexistent allergies, like food allergies, which may present as a wheal and flare type of thing, or rarely anaphylaxis, or allergic rhinitis, or occasionally eosinophilic esophagitis. So they certainly have an increased incidence of allergies, but it in itself is not an allergy. And I often say, well, you often to the parents, if little Johnny, nothing but distilled water passed his lips for a month, he would still have atopic dermatitis. And we now know there's immune and epidermal barrier function dysplasia. And I've only got these last two bits here because a lot of the new therapy that we're still waiting on, but the rest of the world has, are the new biologics against some of the interleukins and some of the JAK inhibitors that are proving really good for severe atopic dermatitis. So the basic is they have a loss of profilaggrin. Filagrins are protein. They have gene mutations, gene abnormalities. They have a poorly formed stratum corneum. That's where 90% of your skin barrier function is. It's their skin barrier function stuffed. They lose water and have percutaneous transfer of irritants and allergens. And I often explain this to patients in the terms of barrier function, and to them, that means they have a sensitive skin, and they all recognize this. So that's the genetic component there, and also they have this immune imbalance as well. And infections, Staph aureus is incredibly important in atopic dermatitis. It acts as a super antigen that stimulates the whole process. So I've just got a very condensed form of this, but I gave a presentation to our meeting last year, 40 plus years of treating atopic dermatitis, and what I've learned and what I've learned to forget. And I started off with old young. Most of my patients were GP referred, seen relatively late in the process. I was over optimistic re-prognosis. You got into interminable debates about allergies and skin prick tests, and we started with weak topical corticosteroids and gradually increased the potency, and by then the patients had given up, and we're pretty reluctant to use oral immunosuppressive therapy. This is a condition that needs to be treated aggressively when they flare up. And most of my referrals, well, I'm not in private practice now, but were word of mouth, treating older siblings or parents, seeing people much earlier, optimism tempered with reality, less allergy debates, less allergy tests. And most people, there are some that won't accept anything less than allergy tests, and they're very useful if they all come back negative. As you know, allergy tests, I've got inverted commas, just because you've got a positive IgE doesn't mean you're allergic, but it can give an indication. And most people have spent years with helpful and inverted commas advice about avoiding this, that, and the other. And most are incredibly relieved when it's not their fault they can't find the allergy. And nowadays, we tend to hit them hard initially, and initially, not long term, with moderately potent or potent topical corticosteroids, sort out the inappropriate use of prednisone. I try and avoid it if possible because it's very difficult to get them off it. I do use it, and I'll mention that in a moment, and we have a much lower threshold of using immunotherapy. So I go through all this with the patient. This will be up on your board, is it a board or a website or something, Lucinda, so people can look at this later on without me reading every line.
Yes.
I mention emollients because people are often acute flare-up. They're given moisturizers, which are wonderful for atopic dermatitis, but totally useless and often counterproductive in that acute flare. So I don't use emollients in that acute flare. The rest of the time I use it by the truckload. Explanatory, the safe and appropriate use of topical corticosteroids, because the nurse down the road's told them they come within 50 meters of a jar of hydrocortisone, their skin will dissolve, and you just manage to talk them into safe use of topical steroids, and then the bane of our existence. I've got lots of pharmacy friends that I have on, but they go to the pharmacist and they get this lecture about how dangerous they are and they shouldn't use them for more than 4 or 5 days and this sort of thing. So you've got to fight all this. So initial consultation, treat the secondary infection. I talk about bleach baths, but leave that till down the track. Moderately potent or potent topical corticosteroids, 5 to 10 days. Occasionally, while I'm waiting, if they're really severe, I don't have any, what's the term I'm looking for, evidence that this is any better than anything else. But if I'm waiting in severe cases for topical corticosteroids to take effect, I'll give them 30 milligrams of prednisone and tell them to drop it by 5 milligram every 18 days. And by the time they get down there, the topical's working. Delay emollients, as I said, and warn them about the pharmacist. And because I have a big rural practice, a lot of my patients are 100, 200 kilometres away. I use a lot of email follow-up. And I advise them once they're under control, I get them to let me know. I then use the initial therapy as pulse therapy at weekends and use weak topical corticosteroids weekdays. No one's going to get into problems using a moderately potent or potent one 2 days a week. And tell them that the first sign of a flare-up, and they know when that's happened, hit it again 4 or 5 days with the potent treatment. Emollients very important here. If secondary infection's a major problem, bleach baths, and I encourage email questions. I might have skipped over it back there, but what I always do to everyone, DermNet, which I'm sure you're familiar with, the New Zealand Dermatological Society thing, get them to look up treatment under T, treatment of atopic dermatitis. There's a very good section there that just goes through all treatments, and I get them to read that before they come back, check their progress. I mean, it's obviously a lot more complicated than this, but I'm just trying to be brief, and then introduce, depending on their response, if immunosuppressant therapy is needed. Often give them a back pocket script for antibiotics and ongoing care. So, as I said, I could talk the whole time about that, but that's a brief overview to managing acute atopic dermatitis.
I think there's a couple of questions for you, David.
Good.
Is there, Gary?
Yeah, there is, David. Firstly, you've already indicated that you don't like to consider dermatitis to be an allergic condition, but frequently patients do sort of see it in that light. Do you have anything specifically about milk allergies leading to atopic dermatitis and whether or not that's likely?
I mean, it's out there, and we come back in 100 years, it'll still be out there. Certainly, people are allergic to milk, but that usually causes a wheal and flare reaction or GI symptoms or whatever. The interesting thing is, once you get their atopic dermatitis under control, unless they've got a clear history of a coexistent allergy, a lot of these people can go back on all the things they've been avoiding. Milk, it's sort of been superseded by gluten. Everyone's allergic to gluten these days, and gluten only ever causes one rare skin condition. So I certainly say to them, I'm not dismissing allergy, but what I am saying is you're not going to fix your atopic dermatitis trying to avoid foods or whatever. Because many of them do have food allergies coexistent with it. And I've got a lot of patients I manage in conjunction with the pediatricians, etc.
Thanks, David. You're quite reassuring about the use of moderately potent and potent topical steroids, and you've warned us off the use of oral steroids for a couple of conditions. But there's a couple of questions around the use of steroids.
Yeah.
And one is, what about the use of topical steroids, particularly in infants and on the face in infants? Mm-hmm. And the second question around steroids, is there other conditions where you think that we should be particularly wary about considering the use of oral steroids?
Right. Topical steroids, it's like anything. If you overuse or abuse them, you cause problems, very real problems. But, and if you're using, say, a moderately potent topical steroid, you can detect biochemical adrenal suppression within about 48 hours. But if you're just using them short term, that recovers in 24 hours, and it's not a problem. There is a very good paper to reassure people. I'll dig it out and send it to you, Lucinda, that you can post up, written by the pediatric dermatologists in Australia and New Zealand. The main author being David Orchard, who's head of pediatric dermatology at Royal Melbourne Children's Hospital. And they don't dismiss problems with topical corticosteroids, but they make it very clear that if you use them appropriately, you're going to not run into problems. And I've been using them a long time now, and very rarely do we see side effects. And the main problem is that patients think, oh, this potent ones work so well, I won't bother going on to the milder one, I'll just keep using that. With regard to babies on the face, often, like that child I showed, once you treat the infection, some children have really nasty atopic dermatitis on the face. And you can use stronger than 1%. Less than 1% of hydrocortisone is a waste of time. Don't bother. 0.5% is a waste of time. But in that situation, you can use Aristocort or Umivate. Ointments are better than creams. At Royal Melbourne Children's, they don't hesitate with those cases to use Advantin ointment. Might be for 3 or 4 days. We're not talking using it 3 or 4 weeks, but 3 or 4 days to get it under control. And the other reason that's becoming increasingly clear, that when babies and young children have atopic dermatitis all over their face, their skin barrier is impaired, and that is a portal of entry of foods, etc., which give them food allergies later on. And if you explain that to parents, that sometimes gets around the reluctance to use them. So that, yes, I mean, Aristocort, it's a very mild topical corticosteroid. It's available as an ointment. If it's a bit more severe, you can use that. Advantin for a couple of days. Unfortunately, Umivate's not available as an ointment anymore, but I mix it in with a bit of emulsifying ointment to make it greasier. Ointments are always better than creams in atopic dermatitis, always. Yeah.
David, Aaron's asking specifically about when the skin is raw. Is it safe to use the topical steroid simultaneously with antibiotics in that situation?
Absolutely. There are studies mainly with hand dermatitis that's infected that show that if you use topical steroids alone, the bacterial count goes down because you're removing the environment. And again, patients and parents are often told, often by the pharmacist again, don't put it on broken skin. Well, the skin's broken because it's full of eczema. Yeah, quite safe. And if they're really badly infected, I might tell the parents to wait 24 hours after they start the antibiotic before they use the topical steroid, but generally they can just use them simultaneously. Yep.
Would you wait for the bleach baths until the skin's healed? Like, does
Yeah,
that,
it's
I mean,
more
just
of
from
a
a
maintenance.
sting?
It's more of a maintenance treatment, because otherwise, as you say, it's stings. Yeah.
Great. Right. Thank you, David. In essence of time, we'll move on to the
I might
next
skip
topic.
that.
Thank you.
In the essence of time. Right. Well, so this is something we see not uncommonly. Just as a case, this was a non-specific itchy rash, 75-year-old for 6 months, not responding to Alicon, then started getting a few blisters, had a 10-day course of prednisone, settled it, but then it came back a week after they'd finished. And this is often a typical presentation of bullous pemphigoid. So I'm just going to talk very briefly, I'm not going through all these conditions, about vesicular bullous disorders, what you'd like to see. Bullous impetigo, you've all seen very thin wall blisters, they often rupture. It's caused by certain large types of staph, often begins around an axilla or around an orifice. Papular urticaria, insect bite reactions. I should have put a picture of my older daughter. She gets a big blister and erythema the size of a saucer whenever she gets an insect bite, but that's often vesicular. They're often grouped as a clue. Phytophotodermatitis, you do see it presenting from time. People present with these bizarre sort of linear blisters. And this was a guy who was a hot day, he was out using his weed eater, stuff was flying everywhere. And often people get on their hands and forearms when they've pulled out their old carrots and parsnips in spring. And a lot of plants contain a psoralen compound, which sensitizes them to UV light. And they get these bizarre linear blisters, which sort of heal with pigmentation. So if you see something strange like that around, especially around hands, forearms, feet, ankles, always think of phytophotodermatitis. Fixed drug eruption is blistering. These are strange drug eruptions, occur with many of the same old common drugs, including paracetamol. You get this blister or intense swollen erythema, often blistered, fades to leave a grey pigmentation. And so you got that from cotrimoxazole. If you never took a cotrimoxazole for another 20 years and then took one tablet, you'd get the same reaction in the same place. And often if you see these on head and neck, especially eyelids, hands and feet, penis and vulva skin. Acute generalized, these are ones that you're more familiar with than me, varicella these days. Acute autosensitization dermatitis, just very briefly, if sometimes people have a major flare of varicose or contact dermatitis or nummular discoid dermatitis, suddenly their whole body packs a sad and sympathy and they get this multiple vesicular eruption. One thing not to amiss is eczema herpeticum. People who are atopic, especially those with atopic dermatitis, their immune system has a total blind spot to the herpes simplex virus. And these people can very rapidly get disseminated herpes simplex that you can sometimes, before they crust, see the little umbilicated things. And if you see a patient with severe eczema that looks like it's badly infected, but they're complaining of pain and they're febrile, well, pain and fever don't usually occur with atopic dermatitis. Always look closely for these pock marks, because eczema herpeticum, they desperately need this. This had a significant mortality before these drugs were available. So I'm going to finish just talking on bullous pemphigoid, because I get a lot of GP referrals about this, and most people recognize it, but are either not confident or uncertain how to treat it, and they can treat it very easily. So it's becoming increasingly common. 90% of people with it are over 70. And so with the aging population, you're going to see more of this. And basically, it's an autoimmune disease. Their immune system no longer recognizes their basement membrane and the epidermis as part of them and attacks it. And so they can get prodromal sort of eczematous-looking rashes for months and then get blisters, or the blisters may just occur out of the blue. And their tense blisters remain intact for a while because these are subepidermal, so they have the whole thickness of the epidermis as their roof. I've mentioned that. When you're doing a biopsy, this is very important at this, either excise a small new bulla or take a radial biopsy of a relatively fresh, larger bulla, but include some normal skin because most of the pathology is at the transition. And you should send some tissue fresh, a punch biopsy of normal, clinically normal, but perilesional skin. Send fresh, either sitting on saline soap gauze or moistened with a bit of saline. It'll survive a day or two refrigerated like that, and send it for direct immunofluorescence studies, and that is the ultimate diagnosis of this. So histology, and if you, we'd highly recommend you send for immunofluorescence. So you may need to initiate treatment if there's no urgent dermatology appointment. Treat secondary infection, wound dressings if necessary. If it's mild and localized, you can get away with Dermol and doxycycline for its anti-inflammatory action. If they're more severe and generalized, then you need prednisone. And the thing about prednisone, you need to start on the decent dose, 40 to 60 milligram a day as a single morning dose. And you keep that going until new bullies stop appearing, not until all the old ones have healed. So they may be on that for 10, 14 days. And then there are no hard and fast rules. Other colleagues of mine will do it differently. But once they're stopped producing new bully, I reduce it by 5 milligram a week until they're down to 20 milligram, and then I drop it by 1 milligram a week. If you cut it off too soon, it'll just come back and be more difficult to control. And any recurrence, if they start getting a couple of new bully, you can go back to the dose that previously controlled it. So I spent a wee bit of time on bullous pemphigoid, but you certainly will see it increasingly because of our population.
Now, David, I definitely want you to go on to the COVID stuff. So should we race on to that? There is one question. Can you just clarify around the biopsy samples? My understanding is that you don't want any sample going into formalin, do you?
No, the routine, the first, right. This one here goes into formalin, sorry.
Right.
You want routine histology on a new bulla or a radial biopsy there. But they cannot do immunofluorescence studies on formalin fixed tissue. So you need 2 biopsies. And this second one, the punch is fine. You can just take a punch of perilesional, clinically normal skin, send it off fresh. So yeah, 2 biopsies. The first one, you just do your routine histology. The second one goes fresh for immunofluorescence studies.
Brilliant. Let's move on to COVID. Thank you.
Now, this COVID presentation I gave last year, I think it was, at a physicians meeting, or most of it. This was before Omicron, and a lot of it was from North America and Europe, where unvaccinated patients were getting infected, and obviously there was a huge death toll and morbidity, etc. So it's more based on that rather than probably our vaccinated population nowadays. But just very briefly, cutaneous manifestations. One of the first ones reported, and I'll expand on this in a moment, was chilblain-like lesions, out of season in young people. As you might expect with any virus, urticarial vesicular eruptions, maculopapular rashes, livedoid I'll talk about, and vasculitis. So these were the things here. So urticaria, papulovesicular, chilblain, livedo reticularis, I'll talk about, and vasculitis. So what causes these? It's probably a hypersensitivity reaction, interferons, coagulopathy, microangiopathy, direct viral damage, all sorts of theories as to what causes it. Chilblains are commonly seen, as we're well aware, following exposure to cold and damp environments, less commonly seen in warmer environments. But it was one of the earliest and most commonly described cutaneous manifestations, but a lot of these early patients didn't even have PCRs. They were called COVID, and data, and these are the typical chilblain-like lesions, some with a bit of a blister, and data really didn't support it, but more recently they've shown the SARS spike protein in endothelial cells of these chilblains. So it does seem it's an association. The typical viral rash, 41% in a big series, urticaria 30% of cutaneous eruptions, not patients with COVID. Patients with COVID who had cutaneous eruptions. Acral, chilblain-like lesions, vasculitis, livedo. So maculopapular, urticaria, chilblains. Livedo reticularis is this sort of chicken wire appearance. You can get it in lots of situations where there's a vasculopathy, like in lupus, like in antiphospholipid syndrome, various forms of vasculitis, etc. But it does occur with COVID. And again here, usually the lower limbs. And vasculitis, which is acute, an acute leukocytoclastic vasculitis where you get palpable purpura and ulceration, etc. As I mentioned earlier, erythema multiforme. If you see a patient with erythema multiforme at the moment, you certainly need to exclude COVID. It's probably the most common cause. Post telogen effluvium, that post major illness hair loss occurs 2 or 3 months later, and the nail equivalent Bowes lines, and there's probably going to be a lot of others as well. So that's typical erythema multiforme, as you're aware, and in a child with COVID, telogen effluvium, hair loss, Bowes lines, and the nails when they grow out. Nail starts growing back here. So when that groove was back there, that's when the patient had COVID and it grows out, just like it's the equivalent of telogen effluvium. Usefulness. In the UK, they had a big survey of 11,500 people. 17 reported skin rashes as their first presentation. 21% reported skin rashes as their only clinical manifestation. So that's just those again. And I think that's that.
Thank you, David. Gary, I'm going to hand over to you because obviously COVID is very topical, isn't it, currently? So there's a couple of questions.
Okay, Lucinda, as is the COVID vaccine. So the first question, David, is are there any dermatological reactions to the COVID vaccine that you're seeing?
Yeah, there are. And I had it, but in the interest of time, we cut it out. I mean, obviously the common ones, the COVID arm, we've all seen that or probably had it. But there have been chilblains reported in response to the COVID vaccine. There's certainly, as you get following lots of viral infections, a lichen planus-like eruption. People who have chronic spontaneous urticaria, you know, just that chronic urticaria that goes on, often will get an exacerbation like they will after any vaccination or a viral infection or an immune stimulation. You can occasionally get the maculopapular rashes. just anything you'd normally expect after any viral or vaccination type thing, but they're relatively uncommon. I had one patient who had a flare of his gut-8 psoriasis, insisted it was due to COVID. I haven't seen it reported, it probably has been, but I haven't had it in any of my other psoriatic patients, but I suspect it was the sore throat he had a week or two later, not the COVID that triggered his gut-8 psoriasis, but who knows?
Thanks, David. Are there any specific treatments for the skin reactions associated with COVID, or are we just talking about the supportive management that you were talking about previously?
Yeah, I mean, if it's urticarial, that's one of the indications for antihistamines. I didn't mention antihistamines in atopic dermatitis because unless you've got coexistent allergies, antihistamines are next to useless in atopic dermatitis. So antihistamines, and then you've got specific treatments of this vasculitis.
Thanks, David. Lucinda.
Brilliant. Well, I think we have truly taken full utilisation of your time, David, and your expertise. Thank you for giving us the privilege of being your last webinar. Obviously, I don't know if you've been able to see some of the chats. Everyone's like, we've got no dermatology service in our area or our area. So when you retire in November, you could always become the #1 contact for rural New Zealand, and we could all have you on our speed dial and we could email you photos. So, you know, if you want to have an ongoing professional career.
When I was in private practice, there wasn't a day went by where 2 or 3 GPs in our area didn't email me the photos and things. Yeah, I don't do so much now that I've restricted my practice, but I still do for South and Hospital. But no,
I won't put your email on the information I send out at the end, or put it on Leaning on the Fence post. You may get inundated.
Yeah.
So on behalf of all our rural practitioners who are here this evening, thank you very, very much. If everyone could please fill out the feedback form, even if you don't want the CME points, we're all for further input. I'd love to know any further topics that you'd like us to cover this year, next year. Just to remind you all that I am full swing into organising the rural workshop based in Tauranga, Papamoa on the 26th to the 28th of August this year. We have some very exciting speakers. We're going to be covering GI, mental health, ophthalmology, covering some clinician wellbeing. I think it's going to be lovely. It's a beautiful spot. So the information is up on the Leaning on the Fence post website and also on our rural CME. I will send you a link. Registration. I have been trying to organise a registration link, but all I keep getting from the Otago web team is we are very busy with unprecedented demand due to COVID, and I will get back to you soon. So due to unprecedented demand from COVID, I will get back to you soon with that. And then at the end of May, we are going to have our next webinar with gastroenterology and inflammatory bowel disease with Prof. Richard Geary. So I look forward to seeing you all then. Thank you very much for your time. Ka kite.